Okay.
Yes.
Okay, so yeah, as ma'am said, so today we are going to discuss something a bit separate from the physical aspects. Actually, we are going to explore more about the psychosocial aspects and how it is involved in palliative care and how it is more important in palliative care. So yeah, if we are taking patient's welfare, I think clinical zone doesn't make a complete fruitfulness to the patient. Am I? What do you think? What do you feel? Are you people also going with my opinion? Does psychosocial aspects plays a role in palliative care?
Already there are few responses telling that it is essential, true and
Yes.
essential.
Yes. So yes, as you people said, it plays a very big role. I have to say it plays a very big role because a 90 percentage of their problems or concerns falls in this criteria. Though we say about pain, and we are more concerned about the physical pain, we sometimes neglects or we sometimes forgets to explore more about the other pains which they carry on in their life, especially when we look into a field called palliative care. So I think it should be more specified and it is more important to explore as well as to get more in-depth knowledge in it. So yeah, I will be explaining more about what is psychosocial and how it is more important in palliative care and how we should deal or intervene the more psychosocial aspects in palliative care.
Hello, Sangeet. Is it okay?
Yes, ma'am. Just a technical.
Okay, carry on.
Okay, so yeah, this is, I think it's familiar to everyone. What is palliative care? So, as per WHO, we can explain palliative care as an approach that improves the quality of life of patients and their families facing problems associated with life threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, especially physical, psychosocial, and spiritual. So here we are mentioning clearly that it is we focus more on the quality of life. And in that, we can say that it's not only patients, but also their families. In what all manner or in what areas or in what categories, it is basically of life-threatening illness. And here we are early identifying it, and through that we are trying to prevent and provides a relief for the patients. In what all areas? It's in physical, psychosocial, and spiritual. So, so this is a small journal which I. So this is a small journal which I took from Indian Journal of Palliative Care, and here this is an article by Irene Tanchel. She's a social worker as well as she's a nurse too. So here she narrates few points or explains a few sentences, which is like this: the quality of life for patients and the manner of their dying is sometimes more influenced by psychosocial factors than by physical factors, physical status. So this is something which we have to rethink actually, because here it's explaining that a manner of one's dying, it's more influenced by psychosocial rather than the physical. So even in matter of dying, we can understand that we focus more on the psychosocial rather than the physical. So this explains more important of what is palliative care again. So as I entered with the important question, go into that, why it is important, why psychosocial care is important in palliative care. First and foremost, palliative care, as you all know, palliative care are the ones who are carrying or living in a very dreadful situation because they are the ones who are having either life limiting or life threatening illness or serious chronic illness due to their lifestyle, disabled ones, or the families who are having these disabled ones and old age people, the ones who are having chronic pains, etc. Those categories comes under this palliative care. So we can, like, obviously we can think that they are not in a very good mental as well as physical state. They are going through some kind of stresses, some kind of challenges, either be the patient or be the family. So for them, there will be some sort of stresses which they are facing day to day life, and which is more important should be assist or intervene. The second point explains that the factors related to these patients' quality of life is essential in providing appropriate care. So just by simply hearing all these challenges or just by simply hearing all these stresses doesn't make any sense. We need to understand or we need to identify the root cause of these problems, which may be different factors will be there. So we have to understand what is the factors which is making them get more stressed or which can be influenced or which can be helpful in improving the patient's quality of life. Third point explains that as palliative care is a life affirming approach, the psychologist similarly focus not on identifying and addressing distress and pathology, but also in enhancing well-being. This includes validating individual and family strengths and promoting source of meaning and purpose supportive of the family system. So this is not a single teamwork. This is a multidisciplinary work. Here includes doctors, nurses, social officers, psychologists. They all together work to identify this distress of the patient as well as their family. Then only a meaning of life can be improved or the purpose of their life can be improved of the patient as well as their supportive family members. And the fourth point explains that psychosocial support helps in reducing the level of actual and perceived strength. So there is a difference between actual strengths and perceived strengths, right? So something which will be thinking may not be the correct factor of that particular stress. We may be perceiving it as, like, for example, thinking about the future and perceiving it might be become a stress in future, but that is not the actual point of stress at right on that right particular moment. So this through this interviewing we get an idea or we get a knowledge in understanding the factors and thereby providing them psychosocial support, which will help those patients and their families in reducing this actual level of stress or the perceived, or in differentiating the actual level of stress and the perceived level of stress. And this is done through the psychological and social interventions. So these are the more important reasons or factors which tells or explains that psychosocial care is important in palliative field. I think it is clear. Should I need to explain a bit more? Can I move forward? Okay. It's clear now? Okay, fine. So yeah.
You can move, dear.
Okay.
They've mentioned it's okay and clear.
Okay, ma'am. So yeah, total pain. So here we are explaining what a total pain is. Basically, what I see during the assessments when these palliative patients comes to us is this: there will be a pain scale, which the doctor asked the patients like, how much pain do you have? And this patient will be telling like, okay, I'm having this kind of pain, or a numbness pain, or a kind of something it is inserting inside my bones or my skin, and that kind of pain, but I don't know how to explain that. So these pain all these patients are, or the doctor is explaining or exploring more about the physical pain what they're having, but that doesn't make a complete sense of this total pain. When we tells about the total pain, that is only not only physical but the other three aspects, that is the psychological, socioeconomic, and spiritual also comes into factor, which explain what a total pain is. Here I have seen a patient in our IP. Actually, he's a long, like he has been registered long back, and in between, like as frequently, like 3 months, 4 months in between, he used to come and tells that he's having pain. We doctors, we clinical team try to explore what the correct factor behind this pain. We tried so many medications, like pain medications, basically morphine, etc. But still, this patient's pain is not being reduced. At last, through the psychosocial intervention or through exploring more by communicating with him in detail, found that he is having the concern regarding his family. Since he is a person who is not married and only mother is alive, no other siblings are there. They are living together uh, in a home where no other support systems are there. So he is actually concerned about what will be happening to my mother after my life. So that thinking process is making him get more worried and more anxious, which increases his pain. So here we can say it's not the physical pain that makes the sense, but the total pain, or specifically, if we say, if we are saying it's a psychological pain and the family concern, it's increasing his body pain actually. So there are situations or there are patients who are explaining pain not because of physical, but rather because of the other content or the other factors which we need to explore. So yeah, telling about total pain, when a patient reports his or her subjective pain on the pain scale, it is important to remember that it's not the physical pain is reported by the patient. Rather than that, it's a compound factor. And in this compound factor, there are some factors which are psychological, socioeconomic, and spiritual, which tells the pain of the patient. Okay. So moving forward, how this pain can be assessed? As I said, through assessment and through exploring. And this assessment is called as psychosocial assessment. So what is a psychosocial assessment? It's an evaluation of an individual's mental health and social well-being. So there it's a connection, it's a connected compound between a mental health as well as a social well-being. So by examining these two areas, we will get the correct factors or the causes behind this total pain or behind the areas rather than the physical which affects the patient. And this exploring or this examination is called as psychosocial assessment. So in this assessment, what do we aim or what is our primary focus? Of course, it is to identify the problem areas. So, as I said earlier, there is a difference between actual stress and perceived stress. So, it like for the patient, maybe like they will be telling about these problems, which is not the root cause of the actual problem. So, we need to identify what the problem area is, which result from this illness and may influence the well-being of patients as well as their families. So, what are things are involved in this assessment? First and foremost, obviously collecting information. In this collecting informations, we are exploring more about the patient and the family. We are like going in deep into their family aspects, into their psychological aspects, into their relationship between the family, with their colleagues, with their peers, with their community, etc. So we are collecting more information, as much as information should be collected in through the during the assessment. And the second one is identifying and honoring strengths, resources, and needs. So after collecting all these informations, we are identifying which is the problematic area and which should be strengthened more and which should be deleted, or is there any resources which should be added, or is there any needs which should be fulfilled. So through this information we will be categorizing all these into separate areas, and from that we will be identifying it. We will be trying to intervene with any resources, or if it is like that inner strength should be more improved, then we have to go for such kind of intervention. And if rather than that, if there is some needs regarding the patient or the family, then that has to be identified and fulfill that. So in this manner we will be providing the psychosocial intervention. So is it clear like what is psychosocial assessment and their aim and how we are getting information? Should I need to explain more in this area? Is there any queries in this area, like what is psychosocial assessment? Okay. So moving forward, so these assessments can be segregated into different areas actually. First one is general. Second one is patient and family overview. Third one is insight, and fourth one is family structure and dynamics. So this is the basic areas of getting information during an assessment, basic areas. So in first area, like as we all used to inquire general informations, like social demographic details, we can tell that. So we will be trying to identify the patient and their family. Is they are having like insight about the diagnosis or the disease, like how much environmental assessment they have, how much psychological distress they have, the spiritual impact of illness, and the intervention and plan regarding it. Coming into the patient and family overview, when we go detail into that, like the demographic details of the family, the occupation, if the patient was working before, then his occupation, and if he is still working, then that also should be mentioned. And at present, if he is not working, then who is the caregiver, who is the breadwinner of the family, and who is taking care of the patient, and what is the relationship between them. So inside we can tell like how much they are having the awareness about their illness. Do they know about the prognosis of their illness, and is they are aware about palliative care, and how much knowledge they have regarding the palliative care. Then coming to family structure, here we can we should know what is the genogram of the family, their family dynamics in the sense how much connected they are. Do they have any support system other than the family members inside their family, and history of illness, like is there any illness history inside this family. So yeah, so these all will be explained or intervene more in these basic areas of assessment. So moving forward, so this is the areas on the terms of the four aspects, that is physical, psychological, socioeconomic, and spiritual. So in the physical aspects, as you all know, we will be assessing the patient's pain through the pain scale, through after interviewing the patient and identifying their illness history and all. So coming to the psychological aspect, we will be exploring their mental health, how much they are, how much strength they have mentally and emotionally. Is there any anticipatory grief inside them, and how they are coping with the current situation, or with their current emotional and mental stress. So this will be explored more in psychological aspects. Coming to the socio-economic part, do they get enough food? Is they having proper clothing and shelter? Who is the breadwinner of the family? And is there any other source of income or supporting people through which their social and economic aspects is being covered? Uh, do they have any debts? Is this social support includes the support from the government system, or any schemes, are they under any schemes of government like that? And is their family, if there is any children, is are they getting proper education or not? So these are the basic socio-economic aspects which we used to cover. Then coming to the spiritual aspects, the connection, how much they are connected within them and outside them. Do they have any strength, or are they finding any comfort zone inside them or outside them? uh, do they have any hope regarding their life, and is there any concerns which they are undergoing in their thought process, and are they finding any meaning in their life, and also are they finding any joy in their life? So these all aspects will be covered under spiritual area. So this is the basic areas which we use to explore more in psychosocial aspects. Should I need to explain more, or is there any queries regarding the areas of assessment? Okay. So genogram. So we are going to some a different area from the assessment. So here in the family structure, I have mentioned we will be looking the family structure or the dynamics. In that, I have mentioned about the genogram. So detailed aspects of what is genogram and how it should be uh, identified or drawn is explained here. So genogram is basically a graphical representation of a person's family. And in that in that graphical representation, we will be explaining at least 3 generations of that patient. And this genogram was introduced by Murray Bowen. And here we will be explaining or exploring more about the structure, like the structure of the family, how it is, the connection or the dynamics, how much they are connected inside and outside, and what is the strength of the family, and is there any resources or helps which which they are being provided with. So these all areas will be covered in a single graphical representation, and that is called as genogram. And in that we will be putting the informations like name, the age, their educational and occupational profile, and also their emotional relationship. So going to genogram in detail. So these are the symbols which we use in drawing a genogram of a particular patient and his or her family. So the first square we can see as male, and the circle is called female. And if it is a line drawn between them, we can say that they are married. And in that, between one slash is there, the third diagram, which shows they are separated. And in the fourth diagram, there are 2 slashes, which explains that they are divorced. Okay, so once again, the square one is the male, the circle is a female, and if it is connected with the straight line, then they are married. A slash in between is separated, and 2 slashes explain that it's divorced. Okay, so on the right side, a circle with straight and a dotted line, it shows that it's an adopted child. And if it is a dotted line with either a square or the circle, explains that it's a foster child. And if it is a triangle, then it's pregnancy period. And if it is a square crossed, it's stillbirth. And a small circle or the small square explains that it is a miscarriage. Crossed line explains its abortion. And from a point, two lines are there in which either two circles or two squares explains that twins. So this is how we draw children in a genogram, the symbolic representation. Okay, so you can go through this, and the next step will be explained by anyone among you, anyone of you. So, any queries in this regarding the symbols? No, okay. So, here this shows the emotional relationship. So, in the basic symbol, we are explaining a bit more with the emotions. And the first one, a single straight line, shows that it's a plain or a normal relationship. And in that itself, a green dotted lines shows that, yeah, they're having a friendship or not that much close, but yeah, a close relationship. And the third diagram shows that they are having a very intimate relationship or they are very much closed. Then it will be a double line, a bit darker too. The fourth one shows that it's a bit scribbled line. It's a red in color, which shows there's some kind of hostility is there in the relationship. And the last one shows that it's a bit darkened and a bit more scribbled. So that shows that they are having a violent relationship. So first, a dotted line is close, but not that much close, a kind of high by. And the third one shows that a bit darkened and straight line, which is a very close or intimate relationship. The fourth one shows that it's a hostile, and the fifth one shows that a violence relationship. Hostile, a little scribbled, and violence is a bit more scribbled. Okay. So coming to the right side, the scribbled line explains the emotional abuse. And if it is a double scribbled line, then it is a sexual abuse. And the third one shows the arrow from square to circle, which shows that they are having uh, an abuse from square to circle. The arrow shows the way, like from where to where, from where to where. It's been shown by the arrow. Okay. Going forward, so this is the simple genogram of a patient. So, like I will give an explanation. After that, I think one of you can explain later. So, always it is easy and better to start from the patient. So, here Sindhu is our patient. She is marked with multiple lines. Okay. And these are her parents. This is Mohan and this is Leela. Crossed, so we can say that he got expired. And Leela, she's 60 years. She's a home baker. Then again coming to Sindhu, she was first married to Raju, and in that relationship they had a son. His name is Saran. He's studying in 11th standard and he's 16 years old. So Raju was a coolie worker, but he also got expired. Later, she got married to Shaji. He's 45 years old. He's a mason. And in their relationship, they had twins, Amal and Vimal. Twins, it is from a point. So we can say that they are twins, both 13 years, both are studying in 8th standard. This is the family of Shaji. His parents are there. Kumaran and Laila both got expired. So here, from single glance itself, we can see that Sindhu is a patient and she got married twice, and Her mother is a homemaker, and Shaji is her husband, and they are having 3 children, one in the first marriage, and two others, both are twins in the second marriage. So without even asking or without even exploring much, from single glance itself, we will be getting a clear picture of what is that patient's family is. So this is a simple, general, basic genogram of a patient and her family. Okay. Do anyone want to give a try in explaining this? Is anyone ready? Can give a try.
So here Sindhu is our patient, and she was first, her parents are Mohan and Leela. Mohan is expired. Leela is a homemaker, 60 years old. Sindhu was first married to Raju, who was a coolie worker. They had a son that was 16 years old now and studying in 11th standard. However, Raju expired, and Sindhu is again married to Shahji, that is, he is a mason. And Shahji's parents are Kumaran and Laila, and both have expired. And both of them have twins, 13 years old, Amal and Vimal, and they are in 8th standard.
Okay, great. So thank you. Now I'm going to bit spice it up. So this is also the genogram of Sindhu itself, but a little more decorations are there, I think. A bit emotional relationship is also explained in it, as you can see. So yeah, I will be explaining it, but before that, does anyone want to give a try? Because it's the same genogram, but a few members are bit added also, and yeah, their emotional relationship is also explained. It's easy. I think it's easy. Is anyone ready to give a try?
Sindhu's siblings are Indu and Bindu,
Yeah.
and Indu's married to Mani, and Bindu is married to Ravi, a driver, and so Shaji's relationship with Sharan is abusive. Am I right?
We can say it as a hostile relation.
Hostile relationship.
Yeah.
With Sindhu's son from the first marriage.
Yes.
And Shaji has two other siblings, Veena and Subhash.
Is
Their relation.
Veena and Subhash.
Subhash.
So is Veena
So
the sibling?
No. Subhash is a sibling, and he's married to Veena.
Yes.
And they also have a hostile relationship towards Shaji.
Yeah.
Vimal and Saran have a close relation.
Yes. So Vimal is having a close relationship with Sharat. And here 2 lines are there which shows that Shaj is having a normal
Shahji is having
relation.
normal relation with Amal and Vimal.
Yes. So what about this green line?
They are very close.
Yes. So Sindhu
The
is
sisters, and Sindhu is close with the
siblings.
her son and siblings.
yes. Also, Sindhu is much more having affection towards her
Correct.
elder son. Yes, Sharad.
Eldest son.
Okay. So I think again, there is no need of explanation. I think so. So what you have said is right. So Sindhu, she's having two siblings, Indu and Bindu. Both are married. Indu is married to money, and Indu is married to money, and Bindu is married to Ravi. Bindu is a homemaid, and Ravi is a driver. And yes, she's having very good relationship with Indu and Bindu, and her eldest son Sharat. With him also, she's having a very good relationship. But his second husband is not having a very good relation towards Sharat. They're having an hostile one, and he has one sibling, that is Subhash, his brother. He's married to Veena, and both of them also having a hostile relationship towards Shaji. And coming to their children, Amal and Vimal, in this, Vimal is having a close relation towards Sharat, and his father is having a plain or normal relation towards their both children. So this explains the dynamics, the family dynamics. Here we can see the family members, what is their age, what is their name, what is their occupation, and did you notice one circle here? So
दोन्ही पण
why?
जाता येते पंचवटीकडून इंजिनिअरिंग कॉलेज
So why they are enclosed in a circle? So this shows that these all are the members who are living together. So when it comes to the members who are living together, those members will be enclosed in a circle. So here, Sindhu and her family, in that husband is there, her three children are there. So they all are living together in a single home. Okay. So that can be explained like putting a circle or drawing a circle in it. So here, like everything, it's clear, like the family, the members, their age, their profession, how much connected they are, how much, how much is their depth of the relationship with each and everyone in the family, and who all are supporting them. So all these can be explained in a single graphical representation, and this is called as genogram. Okay, so I hope it is clear to everyone. Is there any doubts or clarification? Can we move forward? Okay. So, till now we were explaining about how a patient and her family is connected and enclosed they are. And coming to the next part, here we will be explaining how much this patient and his or her family is connected to the society, or what all factors are influencing the patient and their family from the social areas. So this is explained by Anne Hartman and Echo Map. So here we will be explaining as same as earlier, that pictorial representation is there, and in this, the patient's family is how much connected to the social environment. That relationship is explained through echo map. We can say that as a snapshot view of important interactions of patient's family with other systems. The systems includes the groups, the extended family, their individuals, or the organization, or the associations, or even the colleagues, the areas where they're working, their peers. So all these comes under the social area, and that can be explained through a echo map. So this is much more easier than the genogram. So this is the family unit. This will be the patient and his or her family unit, and the other areas can be any category, like either be the school or the clubs or the friends, religious institution, community services, government services, workplace, neighbors, health service, volunteers, anyone. So in all these areas, how much they are connected, and like how much in deep they are, or is there any hostile relationship from these areas, from the social groups, etc. So this can be explained through an echo map. So going towards the echo map. So this is a small pictorial representation of an echo map. The circle here explains the patient and a family. Several categories are there. The areas or the social groups through which they are connected, through which they get supports, and the arrows and the diagram shows how much, like what sort of relationship they are. Is it a deeper one? Is it a strained one? Is it a hostile one? So this is the echo map. And here the straight line shows it's a positive or the normal relationship, same as what we explained on the genogram. The dotted line shows a weak one actually here. Earlier we were telling about a close relationship, but here it shows about the weaker relationship. And as earlier, the scribbled line shows the hostile or the stressful one, and the arrow shows the energy flow, like the wave from where to where they are connected, or in which wave they are going, the energy flow is going on. So yeah, who can explain this, the echo map? It's much simple than the genogram. Just want to focus on the arrows, like from where to where the energy is flowing. Rather than that, everything is same, similar like the genogram itself. So yes, who can come out?
So the patient is the female of the family, the mother, and she's married, and they have one son and one daughter. So that is the family unit living together. So the support system for the patient goes, the energy flows both from the church is strong and she or her belief also. The double arrow on the self group help group support is also there. And there is weak support from the local panchayat members, and volunteer support is there for the whole family unit. And the children, the female child supported well by the school, and the support goes both ways from the youth organization she belongs to. And friend support also is both ways, like she receives and gives support. And for the son also the same way, from the college as well as from the friends. And for the public health center, availability or accessibility is weak for the patient. And for the male of the family, the head of the husband, the colleague support is good, and the whole family receives support from the church and the neighbors or host.
Okay,
The
great.
relationship stressful.
Oh, yeah, thank you. So, yes, as I said earlier, just want to focus on the arrow, like from where to where the energy is flowing. So once again, I will explain once more. Here, this is the small family, and she is a patient here because she is enclosed with several lines. So first we can take the whole family. So from church, if we start from the church, they are having a very good, strong relationship from the church as well as towards the church also. Like it's a to and fro relationship, and it's very strong too. Then coming to the panchayat member, it's a weak relationship. Like the panchayat member is having a weak relationship towards the family because the arrow is shown from the panchayat member to the family. And coming to the neighbor, they are having a very hostile relationship from the neighbor to the family because the arrow is pointing towards the family. Again, coming to the volunteer, it's just a normal relationship, and the arrow is shown as the having a very normal relationship to the family. Then youth organization, the youth organization is having a very good relationship towards the daughter of the family, and saying vice versa, the daughter is also having the very good relationship towards the organization which she belongs to, and the school is having a normal relationship towards the child, I mean the daughter, and with the friends she is having a very normal relationship, and that is vice versa because the arrow is shown from towards both the area. And even for the son also is having a very normal relationship with the friends as well as vice versa again. And from the college also he's having a very good deep strong relationship, that is to vice versa. And from the public health center she is getting a weak support, the patient is getting a weak support from the public health center. And from the colleagues the breadwinner or the husband is having a very normal relationship, and that is also vice versa. Explaining about the self-help group, they are supporting them in a very normal manner, but there is no energy flow from the patient towards the self-help group, they are supporting towards the patient. So this is the small pictorial representation of how much the patient and their family is connected to the social groups. Okay. I hope there is no doubts in this area too. May I move forward? Okay. So we are going towards the end of this presentation. Yeah, caregiver. So basically, we sometimes used to use the term called bystander. In many of the clinics and many of the hospitals, I used to hear the term called bystander. Like, really don't know why we are calling them as a bystander. Is they are a stand or support, or just a pillar-like thing which should be pronounced or which should be called like that? Doesn't they also need, or uh, doesn't they comes, or doesn't they need that respect from our side, seek respect from our side? And one thing which we used to forget is that we all are persons who are going to be caregivers and who all need caregiver one time. So it is our responsibility to show respect, to acknowledge them, and call them as caregivers rather than bystanders. So this is a simple quoting by Rosalind. Here she explains that there are only four kinds of people in this world. One, who have been caregivers. Two, who are currently caregivers. Three, who will be caregivers. And four, who will need a caregivers. So keeping this in mind, we should have that responsibility and courtesy to call them as caregivers, to respect them, and also acknowledge acknowledge their role, what they're doing. Because most of us, whenever even I used to go for home visits and all, we used to get more details, or we used to try to find out how much the patient is comfortable. But we sometimes forget or neglect to ask these caregivers how they have been able to handle their stress, how they have been able to cope up with the patients, and how they have been able to manage their responsibilities and this work what they do. Is they are okay, or is they are fine, or are they being able to handle these situations what they are undergoing right now? At least do we ask them is they are fine? So these are the simple things which we can do when we consider our patients as patients itself. Like it should be it is an important area, like important thing which should be considered. Same as the importance what we give to the patient, it is important to understand and to identify whether they are also okay. So yeah, keep this quoting, like we are also sometimes going to be a caregiver, or we also need a caregiver in future. So moving to the intervention part. So after getting all these information by the assessment or by collecting all the information and categorizing it into different areas, by identifying what the exact problem is or the causal factor is. After identifying all these steps, the final part is what interventions can be done. So here, this is just a few interventions what we used to provide here, which are, first one is providing information, because most of the patient and the family doesn't know what to do or where can they be go for better information, whether be regarding the illness, whether be regarding the provisions which they get from the society or the support, or even about palliative care. They are not aware about it and they doesn't know where to go and collect the information. So providing information is the first and primary thing what we identified from the assessments what we did. And psychoeducation, providing them the perfect or the exact education regarding their problem oriented, like regarding the problems. And supportive counseling, if they need any supportive counseling based on their psychological issue, that should be covered. Follow up, of course, regular follow up should be there. Are our interventions going on track? Whether they're getting any inputs from those interventions which we are providing. Bereavement support. Most of us believe that the palliative care stops with death, but it's not like that. It continues even after death. And in that comes the bereavement support, because we are responsible to give the patient, give the family the proper bereavement support. And next comes rehabilitation. If a proper rehabilitation should be done, then that has to be acknowledged. Facilitation, proper facilitation with whatever departments they have to be done, and giving them such details, then liaison. So these are the few of the interventions that we use to provide to our patients based on the psychosocial interventions or assessments that we used to take. So we have reached to the end of the session, and this is a small case study which I have taken from the assessments what we have done in our work setting. So this is a 56-year-old lady, Mrs. A, has been diagnosed with CA breast in 2016. She has undergone mastectomy and referred for pain management. She looked very anxious and has no idea about what is palliative care. Adding to that, she has comorbidities, which includes diabetics since 12 years, coronary artery diseases there, and also she had gone through a fracture on leg in the year 2019. Explaining about the family, she's a widow and she has children, but the relationship with children is a bit hostile. And also she lives in a rented home. So I think we can explain each by each the areas. So what all the physical concerns regarding this patient will be there? Can someone please point out the physical concerns what this patient is undergoing? Cancer, pain, malignancy, yes. Fear of disease progression, of course, because she doesn't have any information regarding her disease. Diabetic complication, yes. Mobility issues is there. Anything else? Orthopedic issues, liability of children. Liability of children comes under socioeconomic, I think. So here we can focus more on the physical aspects. Loneliness comes under psychological. Physical aspects, anything? Did we miss out anything? Comorbidities, okay. Artery disease is there. So, yeah, complications, fine. So I think some inputs have come. So we can check what are the physical things what they have. So physical pain, as you said, physical pain is there, fatigue is there, difficulty in walking, mobility issue is there, body image issues are there. So since she has gone under mastectomy, body image issues is also there. So yeah, we have covered the physical area. Then coming to the psychological part. Psychological part, stress. Of course, stress is there. Stress due to pain, okay. Anxiety, yes. Anxiety she's having. She's very much anxious because she doesn't know what, like the prognosis about her disease, and also she is not aware of what is palliative care. So she's having anxiety. Then she's living alone. So does that cause any psychological issue? A person living alone, having hostile relationship with children, will there be any psychological issues? Yes, loneliness. Isolation problems can be happening, which can be led to depression, mental illness like depression. Yeah. So early in physical, we were explaining about the body image issues. So based on that, also she will be having psychological issues. She will be overthinking, or she will be comparing herself with other, like herself with the society, or the women's in the society. So such kind of psychological issues can also become. Yeah, due to economical issues also, that also may add or triggers psychological health, I mean mental health. Okay, I think we have covered, I think so. So we can just cross check. Isolation, emotionally weak, anxiety about future, unclear about her prognosis and palliative care, distress due to multiple illness. Okay, so what we have said was, I think we have covered more points. And yeah, now socioeconomic part. Already mentioned, I think so. A few of them have already mentioned, I think so. So what all things can be there which comes under the socioeconomic? Of course, she is alone and she is living in a rented house. So that, yes, so that will be one of the prior factor that is putting her into more stress. And there is no breadwinner. So she's an independent one, and that also again makes more socio-economic issues. She is detached from everyone, even from her children. So the social support there is lacking. And yeah, regarding the rented house also we have explained. And she's an independent one with, and also she is not going for work due to her comorbidities and due to her disease like cancer disease. So is there anything else which we can explain in that, in socioeconomic part? Do anyone want to add anything else more? So yeah, socioeconomic, strained relationship. So when we look into the family dynamics, it's a strained relationship with the family. She's not been able to go for job. Due to that, financial instability is there. She is responsible to give house rent, which she is not been able to provide, and low accessibility to hospital, absence of caregiver. There is no caregiver, which we have missed out. Here, when we see we are not explaining, or there is no person called as caregiver in this case. So that also again adds more stress, both in social aspects as well as in psychological aspects. So hence, the support system what there is lacking a lot. Okay. So spiritual aspects. What are spiritual aspects can be identified or will be there in this particular case? What all spiritual concerns can be looked into? Because we have already mentioned that she is a very much stressed person. She's living alone. She's having no connection with anyone. So, what are concerns which we need to look, which we need to explore in this particular case? Feeling of lost, yes. Despair towards her faith, yeah. No support system. Anything else? Here we can see that her hope has been lost because looking into herself, she finds that there is no such thing called hope, which will obviously will affect her meaning of life, and that will start making her think like, did I do anything wrong in my life? Is it because of the negative things which I have done in my past that had created me or made me put into such kind of a situation? Uh, she may have lost her faith in God. Also, she may have she may have uh, came into a situation where she have lost her faith in her life also, because what should I do again? Nothing I can do. Even my children is not having a good connection with me. In which point she has to get that relief or that hope or that meaningness in her life. So these all things are broken or need to be explored in this particular case. So yes, she's in extreme spiritual distress because she has lost faith in God, she has lost connection with family, no significant person in life to be connected with or to be gone or to have a space where she can vent out. So such kind of person is not there in her life, and no memorable or joyful events because she is having uh, this disease from 2016 and she's 56 years right now. So of course she will be having a long period of distress, and uh, going back, when she looks back into her life, she doesn't find any memorable joys, memorable events in her family. So these all factors puts her into a situation where we can find that she is in a very distressed, spiritually distressed condition. So only if we find answers or only we been able to intervene in all these aspects, we can say that we have done something or we have been able to provide a quality of life in a person's life. So this explains that psycho socio spiritual aspects is more important, especially in a field like palliative care, because palliative care category is a place where persons who are having a lot of stress, or those who are having a lost, those who have lost faith in themselves as well as in their life. So only pointing out or only going to the physical aspects doesn't cover anything. If we want to provide a total quality or if we want to provide a meaning in our patient's life, then we need to explore much of psychosocial spiritual aspects. And by covering all these concerns, only we will be able to provide a perfect quality of life, a perfect meaning in life. So with this, I would like to end up telling what are the importance or what is psychosocial factors is. Just few points to remember: evaluate our interventions. So we have provided an intervention, but with that doesn't, but stopping with that doesn't make any sense. We need to evaluate again and again, because only then we will be able to identify whether our interventions are being fruitful for the patient, or if not, then what has to be assessed, or does this assessment, what we have done or what we have taken, did we miss anything, or some other factors are being, should be interviewed more or should be evaluated more. So these all kind of things can be identified only when we keep on re-evaluating our interventions. This is how the patients and families are being benefited. Assessments have to be revised and updated. It should be like whenever we get an opportunity, we have to take reassessments again and again, and we should have an update regarding all these aspects of the patients. Reach out for help if needed. Even we will be making mistakes sometimes, but reach out if any help is needed. There is an art and science in psychosocial care, just as in medicine. So with this, I wind up my psychosocial session, and thank you all for listening. Hope you got an idea about what a psychosocial is and how the assessment has to be taken, what are the points or what are the areas which should be covered or look into more when we are understanding a patient, and what all interventions can be done. Okay, thank you.
Thank you very much, Neeraja. You've taken us through in great detail with examples, and most of like a big applause to the whole team also. See, many of the genogram, ecomap and all, they did it. You took the session and that showed that everyone was actively listening, and the feedback was good. And only one question is there, and we have a case discussion also, case presentation today. Sangeet, can we come out of this presentation? I think Dr. Premnath has put one question. Is it possible to address each and every issue to give a better quality of life? Yes. See, that is what as she mentioned in one of, like, after telling all the things, she put one slide as intervention, which had all that. Like, first you have to explain and then liaise with them, give them psychosocial support, then give some rehabilitation, look into their individual social issues. And for all that, the social, as she mentioned, what she mentioned are some of the things. Pallium does a lot more than what was mentioned in that one slide. For example, I will give some examples. Rehabilitation for children. See, for example, in this itself, you saw if the person who is undergoing the disease has two children, eight, like they were twins studying in 8th standard, there is a scheme entirely helping children in their education, fees, whatever school, whatever they need, like school means books, paying the fees, those type of things are there. Either what Pallium does is they will get in touch with the organizations who are willing to. This can be done not only by Pallium, by anyone, by finding out who are the NGOs available, then making a relation, like having some days, like you can get those organizations to come into the, have one place where they can come, and where the patients, that is demand supply, you make an arrangement where both can meet, and then the help and support can happen. So like that, I said this is as one example. Like that, you can do rehabilitation. Like if there's no breadwinner, when the patient recovers, either the patient or the family, who can be supported in different ways. Like in Trivandrum, they set up like small shops where they can, even if they can't do great amount of mobility, they can do that in their own homes. Or people who are able to move about, they give them some options of doing some small scale businesses. And worst come to worst, if nothing can be provided, they even provide a food kit. So these are types. different, each aspect has to be assessed, reassessed, and taken into care what form of help can be provided. Have I answered your question, Dr. Premnath? Or if not, you can, we can go ahead with the case discussion and then come back to the discussion if I have not given sufficient explanation to your query. NGOs?
Yeah, what I wanted to emphasize was the caregiver may not have that much time to address each and every issue pertaining to the patient on all aspects, psychological, spiritual. Suppose patient doesn't keep a good relation with the children. And one may not, my apprehension is, one may not have time to call and set right the things. Those kind of things, what I meant.
See, one thing, no, perfect. What is perfect in the world is very difficult to get. Something better than nothing. So you can see carer education, respite care. See, sometimes carer can be educated on what to be done, and that is where, always, no, minimum, to have a palliative care setup, we say minimum 3 members are needed: a doctor, nurse, and a social worker. Okay, because one person doing all jobs is not possible. Even it's not possible, this multitasking and all, no, is only said. When you do multitask, is there efficiency in all the tasks? Everyone put your hand on your heart. I am not going to be judgmental, okay? You all can decide how much of efficiency you get when you multitask. Take one small task and multitask at home and see, and do that with whole focus and concentration and see. So because today's world, if I tell that, everyone will bounce and pounce on me, I don't want to. You all judge for yourself. So your query or concern is totally understood, Dr. Premath. Yes, one person cannot and will not be able to do. That is where the support system, if it comes and gives them some relief. For example, I said respite care. One carer may be doing everything 24/7. They may not be able to look after themselves. Many situations I have seen where the carer will end up with some disease. So that is why we say you have to keep an eye on things. See, from day one, what I've been telling, palliative care is an approach for the person and the caregiver. So start looking after the caregiver from the beginning. So yes, not possible. That is where team approach, multimodal, multidisciplinary assessment, multimodal management. I've been telling this as a parrot, maybe every session once. Yes, never mind, because I would be happy if all of you get this into your mind. See, it's impossible. And even in today's sessions, she said that we have to accept, understand, and get help. There's nothing wrong. Sometimes it may be foolish to think that you can do everything, and again, what patient is our best interest. I want the patient to get the best. If I get a big label or not is not important for me. For me, my patient should get everything. So by seeing 3-4 people gets the 100% is no worry to me at all. I'll be happy if the patient gets 100% from 4 sources. So yes, it has to be understood and taken into consideration and dealt and done. And NGOs, and as we were also been telling, and that's what has been connection with NGOs and things are very, very important. Only through that, and this is happening in many setups. There are so many support groups, these type of things are there, and support groups gives many in help, which I will mention after the case presentation also. Sangeet, we can go ahead with the case presentation, please.
Okay. This case presentation is by Dr. Shanmuga Priya. Welcome, ma'am, and over to you.
Good evening, everyone. Thank you, Neeraja, for the presentation. I am Shanmugapriya from Madurai. I am an MDS in oral pathology. Now I'm training as a palliative care physician in the Department of Medical Oncology attached to Madurai Meenakshi Mission Hospital and Research Center. So I'm there as a trainee for the past 2 weeks, and this is one of the case that has been referred to the palliative care unit at the initial phases when the patient came for the OP. So I was there as an observer for this case. So it's a 74-year-old male, and the diagnosis was metastatic carcinoma of the stomach to the non-regional lymph nodes, stage 4. And he is afflicted with type 2 diabetes since 5 years and hypertension since 2 years and on medication. Personal details is a retired government employee who is receiving pension and living with his wife in their native village after his retirement. So he has changed to vegetarian diet in the past 1 year, and he was a smoker and had alcohol occasionally 35 years ago. And now he uses occasional nasal stuffing powder. And his spouse is a senior citizen, 66-year-old, and she's a homemaker, and she has got no other home. Next slide, please. So this is the pedigree. The head of the family, the patient, I have colored it as red. The patient, and he lives with his wife, and they have got one son and one daughter. Both are married, basically. The son lives in Uti. He works there with his family, and the daughter lives with her family in Bangalore. So no other family history of malignancy or other illnesses. Next slide, please. So the patient reported to the medical oncology OPD on May 11th with the complaints of abdomen since 1 week, which worsened after eating solid food, and it was non-radiating in nature. And there was pain in swallowing solid food, but no dysphagia since 1 week. And he complained of constipation for the past 4 days and nausea and vomiting for the past 2 days. So, history of the current illness. The patient was first referred to the Department of Medical Oncology for a consultation by his general physician from his native place on 25th April, when he went for complaint with blood in stools for 2 weeks, loss of weight, appetite for the past 2 months. So his general physician referred him for a histopathologic examination. An endoscopic biopsy of the stomach showed a poorly differentiated gastric adenocarcinoma, after which he was referred to Madurai Meenakshi Mission Hospital, Department of Medical Oncology. After discussion with the family, the patient, when he reported again on 11th, after they have given symptomatic management, the general physician has himself given. So the patient was referred to palliative care physician on May 11th. So when he reported to the department, the team introduced ourselves to the family, and we assessed the patient with the Edmonton Symptom Assessment System. I'm sorry if it is not very clear. So it is a 10-scale assessment system where there are 6 physical symptoms and 2 emotional and 1 well-being scale. So with that, the 0 being the best possible outcome, that is no pain, not tired, not nauseated, and 10 is the worst possible outcome. So we assess that, and the palliative performance scale. This is another scale which gives easy communication among the physicians about the patient's general state of well-being. So as you can see, you can Google this also. So it is rated in the percentages from 0 to 100, 100 being in full normal ability and 0 being the death. So we assess him at to be 60%, where there is ambulation, the mobility is reduced. They cannot do his daily work as he used to. And he needs occasional assistance for walking or doing some self-care. So we assess him being 60% of palliative performance scale. Next slide, please. So on general examination, his pulse rate was 82 per minute, BP 140 per 90, respiratory rate, and oxygen saturation was 99%. And he was conscious and oriented with regard to time, place, and the person. and there was a mild pallor present. These were examined by the nurses in the OPD, and the icterus edema or cyanosis was absent. There was a mild distension of abdomen, but not too worrisome, and it was soft, non-tender on palpation, and there was no palpable abdomen. The evaluation of the pain, provocative factors on eating more while having solid foods. So adenophagia was there, and there were when he was normal, there was no pain, so there's no palliative factors. He was not taking any pain medication at that time. The pain was aching in nature and intermittent only while eating, and it was non-radiating in the upper abdominal region, and it didn't disturb his sleep and during daytime. Only after and while eating he had pain. So his pain was 3/10 on the pain scale, and after eating or while eating, it was 5/10. Next slide, please. So the investigations done on 16th April. He was underwent the histopathological examination of endoscopic biopsy of stomach, and the report showed a poorly differentiated gastric adenocarcinoma with invasion to stoma and high mitotic activity. And on 23rd of April, he underwent CT abdomen, and there was a focal wall thickening with a mucosal ulcer and nodularity in the stomach at the esophageal gastric junction, and multiple nodes were seen. And on 23rd, he went gastroscopy also, which showed a large ulcerated lesion at the fundus of the stomach and an anteropylorus region. And PET CT on 26th of April showed enhanced wall thickening in the body and the anterior pylori of the stomach with multiple intra-abdominal lymph nodes as well as metastasis to mediastinal and bilateral supraclavicle lymph nodes. So the diagnosis given was stage 4 metastatic carcinoma of stomach. Next slide, please. So the treatment plan was the primary physician, medical oncologist, has given the option of palliative chemotherapy versus the best supportive care in view of the best interest of the patient. And the patient deferred the chemotherapy option. And because the patient and the spouse were in diagnostic and prognostic collision, the patient was only told that he is having ulcer by the family, the daughter and the son-in-law and the son who accompanied him. So family members, son, daughter, son-in-law who were present were aware of the prognosis and the outcome and has opted for best supportive care. So then the oncologist referred to the palliative care team for the need. Next slide, please. So intent of the therapy is till end of life care, and the aim of the treatment and referral criteria is best supportive care. So palliative care team introduced ourselves to the family members, and the family members requested us not to reveal the diagnosis and prognosis to the patient. So we honored the request and spoke with the patient regarding symptoms and his queries and addressed that accordingly. He was more concerned about his daily routines, self-care, and the pain factor. Otherwise, so we explored with the caregivers, with the family, our concerns of pollution with diagnosis and prognosis that has been not revealed to the patient and spouse. Then we discussed the pros and cons of pollution. And as the primary caregiver is the spouse, the wife of the patient, and they are living alone in their own house in their native village now. And so she is in pollution, and we explained that this will impact upon holistic care of the patient well-being. That was addressed. And then comprehensive care plan and anticipatory events were discussed with the family members, the son, daughter, and son-in-law. So we also provided the option of hospice care and home care. And upon request by the family, we gave a referral letter explaining the intent of the therapy and the aim of the treatment and the family dynamics to a hospice care in Bangalore as well as in Uti, where the family wanted to have the parents close to one of the children. And the goals of care was next. Next slide, please. Can we go to the next slide?
Just a minute, just.
So after explaining all these, we prescribed the following for the pain. tablet paracetamol 650, TID for 15 days, and Ultraset SOS, metoclopramide for his nausea and vomiting, and bisacodyl for constipation, and the sirapramate. Non-pharmacological management, we advise semi-solid foods, more of liquid diet in smaller quantities and frequent intake. Nutritious and fiber-rich food was advised, and increased intake of water and mobility within his comfort level. So coming to psychosocial aspects, the main concern was the patient and the primary caregiver, whose spouse is in pollution in both the diagnosis and the prognosis. They live on their own in the village where there is not much high-end medical facility available immediately. The nearest city, Tirunelveli, is about 1.5 hours from the village, and both the children are living away from them. Their daughter is living in Bangalore and son's family in OT. And the concern for the patient from the non-verbal cues is role reversal. Now he was a independent government worker, pensioner living in the village, head of the family. Now he has to depend on his son-in-law, son to come and take him. So the role reversal, that anxiousness was there, dependency. He didn't like to be told what to do, and there was no financial burden for the family. The parents were well off on their own, and the children were also not dependent on the parents. So on taking the NCC and guidelines version 1, distress management thermometer, the patient was not aware of the diagnosis. He was just told he is having an ulcer, and the pain was not much. And when we gave paracetamol the previous visit also, he was fine with that. So he is not much worried. Only the change in eating habits and losing some self-care routine and hobbies are what is affecting him. So his distress because of his anxiousness of not knowing what is happening, despite coming to the oncology department, he couldn't open up and ask us also if, in front of the other family members. The spouse was not present. So distress, we say that too, because we couldn't explore the other psychosocial aspects with the patient. Next slide, please. Okay, so again, as we already discussed, it was the patient and spouse solution with diagnosis and prognostication. And patient is not willing to shift from the village. The daughter was asking him to move to Bangalore. So then we, because he feels better with medication and convinced that if what he has got is a stomach ulcer and he will be treated. So we explained to the family during our session the first day that he is not willing to move because he doesn't know the diagnosis and the prognosis. So he doesn't want to go and live with the daughter's family or son's family. So after 2 sessions, after 2 days with the family members, we convinced to get the son and son-in-law to reveal the diagnosis to the patient and the spouse step by step slowly. Next slide, please. So in summary, a 74-year-old old male patient diagnosed with metastatic carcinoma of the stomach stage 4 in pollution with diagnosis and prognosis referred to palliative care, and the family members were explained of the futility of any intensive active therapy, and they were counseled for symptomatic management and end of life care. Symptomatic management was provided, and further goals of care was discussed with them. Discussion points. Main thing is the barrier to communication with the patient because of the pollution. And what about the patient autonomy? Because this is not this one case, this past 2 weeks, whatever the case that has been referred to in the palliative care unit, we are facing the same barrier because the patient, loss of patient autonomy in decision making. And there's a social stigma and fear to reveal the diagnosis of cancer or even use the term cancer among the family members as well as to the patient. They say that they have got a serious disease, they say they have got an advanced disease, they say they have got a big mass, but they never say the word cancer. And the stigma is there. It's prevalent from all socioeconomic status. That is what our experience has been so far. And the palliative care team couldn't communicate with clarity to the patient because the patient's family wants to withhold the information. And so we couldn't explore the spiritual care or advanced care planning like living will or last wish or further goals of care with the patient as such. Thank you.
Thank you very much, Dr. Shanmugapriya. Um, See, coincidentally, I was having a discussion with another doctor who has family in Madurai and Coimbatore facing the same issue. And again, I was telling that this is the current situation. Okay. It is, we have got as Dr. Rajagopal says, we have got a big hill to climb. And one thing he says, one difference is in the last 20, 30 years, he's had a tougher task. He says, at least you are all, we can see some inclination of climbing now to what things his team had to face in the initial stage. So, and thank you very much for bringing up a case which has everything. See, as you were reading the concerns, I was thinking, like all the sessions that you had so far, it is coming step by step. See, what you had in communication, 2 sessions, that is what are your first two queries. Collusion. Okay, it is very important that you have to have a detail. You already said you had 2 discussions. See, 2 discussions was not enough. I remember very well during our communication session, oh, how many times we have to speak? Yes, we have to
Every
say,
day.
and maybe you may need separate discussions with the wife, separate discussions with the son or daughter, son-in-law, daughter-in-law, and also the importance have to be explained of collusion and the pros and cons of collusion, because then for 2 weeks down the line, when he's not getting any improvement, can't eat more, he will ask, why is it happening like this? Why are you not taking me to another doctor?
True.
Okay, so all these have to be explained to both the like the person colluding and the person who is avoided of providing the information. Okay, only then it will be helpful, because suddenly one day when the patient asks, so we have to pre-warn the person colluding, and so what can come forth suddenly. Okay, so these are things. So as I said, those were the 2 things. And then afterwards, social issues, psychosocial issues, and then here pain management was not a big issue. If it comes, how you do. Another important thing is goals of care you have mentioned. Okay, you've mentioned all these goals of care, but with a collusion. So there also, there are multiple challenges to be faced as they go by. But important thing is clarity of all these documentation. You have mentioned that everything has been documented for all. So all these are there, and then as you said, there is enough things can be done on spiritual care support and things which can be done, and but only when it is revealed an advance directive. And that's why we are in a situation in India where many of these things are not even spoken up in many families and situations. Slowly it has to be opened up, time has to be spent to give these information, and then taken step by step. And in the chat itself, I think Dr. Kavita had asked about spiritual distress assessment. I had typed some form like scales which are there. They can be used, and those, there are plenty of skills. Okay, but one of the simple things is what I have mentioned, and these are very commonly used, and plenty of information and articles, recent articles are all available. Even in 2022, there has been an article released on spiritual assessment from India itself. So there are many information online. In the last 10-15 years, lot of work has done on spirituality assessment also, because there are studies which have shown that who have a spirituality outlook manage these situations, this end of life care and palliative care situations better. So we can assess the patient's condition, patient carer, and help them also how to overcome and manage. So in other things, like anybody else wants to add on?
Another thing is the time
Neeraja, you
of
want to?
referral, ma'am. Time of
For
referral
what?
by the primary physician. Also, that was also a barrier to communication. time of
Yes,
referral.
see.
So
So
only at
that one, no,
this patient came only at stage 4, so that is not an issue. So we saw the patient from the start. But most of the other cases, what it is now getting referred to us in only at the end of life stage. So at the terminal stage. So still it is going. The patient also has got, they were in the ward where somebody else is taking a chemo and suddenly we have stopped the chemo because the patient has become catatonic and all this thing. So the time of referral is also an issue from the primary physicians.
no, so that is why, no. So as we all, you have seen in from the first session to know, from the time of referral can be from the time of diagnosis, or even I have seen patients in Adyar Institute when they come into the hospital for assessment itself. But one thing, no, most of these patients, when if it's a tertiary or a big hospital, you may get patients from all parts, and then they might have had the diagnosis somewhere else and they would have come here for another expert opinion. So those type of things will be there. So it is earlier referral benefit and working together. See, in so many sessions you had, like if you all remember, no, in non-cancer, like the session where you had for palliative care for non-cancer illnesses, Dr. Ritula telling that bow tie model. So it works you can work together. But for all that, no, you should have a good relationship between the departments. So, and see, everything, I am telling many things very diplomatically, okay, because we have to be so. So that is how, if it exists in a nice way, the benefit is, see, all this strained relationship, Neeraja, all what you said itself, I'm using. Strained relationship, not only in patient, strained relationships in the departments also doesn't help. So that itself may avoid someone referring. So, but all that should not exist. It should be a good, for example, like you will have bit of both everywhere. But God's grace and blessings, Pallium, we have a lovely morning. We do have a multidisciplinary team meeting of the inpatients. We will have doctor, nurse, psychologist, physiotherapist, everyone in one room. So it is very comfortable to make a decision for the patient for the day, and then we all work together through the day to see the best. And even when we go for home visits, we all go together, depending on the need, which area, what patient, this patient may need this, then accordingly we will juggle our team that morning. Okay, so these are things, that's why I keep telling all of you, please go see Pallium. Even 2 days, 5 days, see to believe. So then you can say, no, because someone will tell, oh, they're telling, does this happen? That's why that's a model unit. Okay, please go see to believe, and then you can practice. And why should you all not be happy and good practicing physicians? Okay, and any other doubt, please do ask. And Dr. Premnath, have I answered all your queries, or is there anything more that you want to be clarified? Is Dr. Premnath still there?
Yes, ma'am.
Okay, it's because I just wanted to make sure, have I answered all his queries? And is there anything else anybody wants to know? Did I say something which, any explanation incomplete or anything like that? Please do ask. And one more thing, what I wanted to ask Dr. Thank you, Dr. Prema. Dr. Prema, do you work in a palliative care center already?
Ma'am, I'm basically an anesthesiologist working in a medical college. And now in the fag end of my career, I'm trying to switch on to palliative care, offering in a place where there is a lot of vacancy.
There is offering in a place where there is need and demand. Is that right?
There is no palliative care exists.
No, see, for anesthetists, it is something because pain management, are things
Yeah.
which is part of the our thing. The only thing is that if slowly you like doing main thing is pain management and palliative care do exist, and many places the anesthetic department runs the pain and palliative care.
Yeah, and we
That is how I
established
have worked in.
yeah, we established a palliative care center here in Pondicherry in our medical college with the help of Pallium India.
So you are from Pondicherry?
Yes.
Okay, okay. Yes, then I think there is that Mahatma Gandhi Hospital. Are you there or?
No.
No, no.
I was in
You're in
Arapadi Medical
Jipmer?
College. Arapadi Medical College.
Okay, okay, okay. Because many places the anesthetic department only runs
Yeah,
the
that's right.
pain and palliative. And there are many models like that you could visit or see. And maybe like that's all. These type of training and hands-on is essential, Dr. Premnath. Nothing equivalent to a hands-on. Working
Yeah.
somewhere for 10 days. Pallium, or there are many centers like you could get in touch with Pallium to give you the centers nearby which you could attend and get some. Like it's just because just to see to believe, as I said, no, as we have been telling all this, no, using morphine for breathlessness and all, we have been doing that right, left, center for many years. One
Yes.
such center is the one in Adyar Cancer Institute that is also run by the anesthetic department. So there are many places which could be helpful, and as you keep doing and seeing more patients will be more helpful. Okay, in that case, thank you to one and all, and a big thank you to Neeraja. Anything else you want to add on, and I pass it on to you and Sangeet now.
Okay, thank you, ma'am. Thank you, Neeraja, for your wonderful presentation. Thank you, Radha ma'am, for facilitating the sessions. Thank you, Dr. Shanmuga, for presenting a wonderful case story. Thank you all participants for participating actively. Thank you. Let's see you in the next session. Bye, ma'am.
Thank you, one and all.